And joining me from Wolters Kluwer is Lee McMillan, Product Marketing Manager, and Raellen Kishbaugh, Manager for Customer Success and Product Development. Before we get to today's slides and the presentation, we will be taking QA throughout the presentation. To the right of your screen, you can enter all your questions. I'll be collating them throughout today's presentation, but we will address all questions at the end of the presentation, and all lines have been placed on mute. If you look to the right of the screen, there's a new handout menu bar. You can click into there and see the handouts for today's presentation. There are CEUs associated with today's presentation. We have CEUs from the AAPC as well as AHIMA. And sometime tomorrow afternoon, a survey will be sent out to you, to all registered attendees. Please fill out the survey, as we all want to know how to better serve you as our customers. And then once you fill that out, you will see the instructions to download the CEUs. Now, it is my pleasure to introduce to you today's speaker. Today's speaker is Kim Charlin. She is the Senior Vice President for Clinical Innovation. She is also the publisher of VBP Monitor. She has 30 years of experience in health information and reimbursement management for hospital and physician offices. Kim's primary role at Panacea is publisher of VBP Monitor, an online news and information service that monitors the transition of healthcare providers from the current fee-for-service payment system to the value-based purchasing model. She is also co-host of the ICD-10 Monitor's weekly internet news broadcast, Talk 10 Tuesday, and is proud, and it's been my pleasure to work with Kim over the last several years, as she has been a long-time coding advisory board member. And without further ado, it is my pleasure to introduce to you Kim Charlin. Kim?
Thanks so much, Maria. And it's a pleasure to be here today to talk to you about the impact of value-based purchasing in the healthcare industry. I'm sure that everybody is seeing things now probably on a daily basis in your inbox, having something to do with value, quality, cost reduction, population health management, as the healthcare industry moves in that direction. When I began this initiative about a year and a half ago, creating this new monitor for Panacea, I was overwhelmed by the amount of information, the non-standardization of terminology, and there's just so much to this that I think folks are having a hard time kind of getting their hands around it all. So I'm hoping that today's presentation will bring some of the basics to you so that you can begin to build upon it as you start to look into the details of the different programs, assessing how they're going to impact you and your organization and how you need to move forward. So today, we do have a disclaimer in here. I'll let you read that at your leisure. But today's objectives are going to be to discuss the current healthcare environment, which I think is important because there's so much happening. We're going to review what the Healthcare Quality Initiative is. We're going to discuss the impact of quality outcomes data on providers and the impact on financial reimbursement. We'll be doing this from a somewhat high level. As I said, there is a lot of detail here. But we also will be discussing what we should be doing as we move forward. I think, again, as people are getting their feet wet on this, we're not really quite sure what we should be doing, as a lot of the functionalities associated with quality reporting, I think, can be fairly disjointed within a facility. So hopefully we can share with you some things to be doing. So let's go ahead and get started and talk about the current healthcare environment a little bit. So of course, everyone is under tremendous financial pressures from all angles. Reduced payment, higher costs to provide services. So that's obviously a very major impact for us. We're also seeing reductions in payments due to MSDRGs and RAC initiatives. We know those are associated with medical necessity, coding, and clinical significance. And clinical significance has really started to creep up within the last year, maybe year and a half, where it's really meaning that we need to show that the documentation in the medical record is showing that there's clinical significance to what we're coding. Before, in the early days of DRG optimization, it was kind of, if the physician says this particular word, we can go ahead and code it. But now we really need to make sure that there is treatment associated with something, that we may want to be reporting, that there are, lab values or findings. There has to be substance in the medical record in order to code and report items. So we're also seeing reductions in outpatient payments due to APC bundling and regulatory audit initiatives. They're, again, medical necessity. We've been struggling with that for years, showing medical necessity for services, and coding as well. And the bundling is really becoming significant as well in that outpatient setting. And I'm sure if any of you have looked at the proposed OPPS rules, you can see where Medicare is addressing more bundling APCs on the outpatient side. So again, reduction in payments. On the other hand, we're seeing an increase in pay for performance and quality initiatives, value-based purchasing, which really is about increasing quality of care and patient experience while reducing healthcare costs. So that's our focus today, is really looking at those VBP initiatives. Also, factors influencing us, peer review organizations are publishing quality scores. So, you can see this if any of you have gone and looked at any of the reports that are out there. I'll have some examples a little bit later in the webcast to show you. But the results of our scores are being published. And there are ramifications happening from that. A few months ago, there was one example. There was a payer, I believe it was in Michigan, that actually had notified 20 of their physicians that they were basically going to exclude them from their plans because their scores, their quality scores, were below what they needed to be. So there are things happening as a result of our reporting. Healthcare consumerism also is big now. Everyday individuals have access to all of this information and data out there through the internet. They can look up, the quality scores themselves. So that's really big. And, for folks that are not in this industry, their interpretation of this data can oftentimes be different than ours, kind of taking things at face value and not maybe really understanding that, those scores are not always what they seem to be, just due to how things may be being reported or exceptions and whatnot. So, but we are under that microscope now from the public. Managed care and third-party payer contracts implications as well. So, our contracts they're trying to cut back. So we want to make sure that we're identifying things or items that we are getting outlier payments for, or being able to know and be able to understand and negotiate smart contracts for being paid for services that we're providing, resources that we're consuming. Data mining. We're going to talk a lot about this today. Data mining is everywhere, and it's basically reflected based upon the data that you're reporting, and a lot of that is based upon that coded data. I happened to read an article this week on data analytics and how data analytics will increase in use over the next 3 years to improve care quality and monitor population health. There was a Health Leaders Media survey recently that showed 95% of health systems use data analytics to improve clinical quality, and 47 of them use data analytics to access and to assess population health needs. But within 3 years of these same organizations, they say that they're going to be using 78% say they expect to use the data analytics to respond to population health needs. So the data is going to be continued to use more and more. So that's why it's really important that we look and focus on and make sure that the data that we're reporting is accurate and supported by documentation. So let's start in with what is the Quality Healthcare Initiative Value-Based Purchasing P for P, it's often called pay for performance. So value-based purchasing is a term for initiatives aimed at improving the quality, efficiency, and overall value of healthcare. Value-based purchasing includes financial incentives that reward providers for delivery of care efficiencies, submission of data and measures, improved quality of care, and patient safety. So the overall goal here is to improve quality, improve efficiency, and reduce costs. Sounds simple enough. So how is quality measured? So it's based basically on reported outcomes. So it's measured based upon diagnoses and procedures that we report. It's based on severity of illness and risk of mortality scores, morbidity, length of stay, resource consumption, cost per patient, your Casemix Index, readmission rates, and patient satisfaction. So all of these items, except for the patient satisfaction, is really relying on some form of data in some form. The patient satisfaction, those obviously are a result of satisfaction forms that are filled out, and patients send those back in for review. So how is quality measured? Many are reported by the ICD-9 codes, and now, of course, soon to be ICD-10 codes. And, I asked the question, have you looked at how your data will be different in I-10 from I-9? We know that there's not a one-to-one correlation between a single I-9 to a single I-10 code. So how is that data going to look? And I have seen from several agencies articles that they've written, like from AHRQ and HEDIS, that they have done analysis themselves, and they feel confident that the data will be similar. But again, it's good for you also to look at your data and see how that might translate, that quality data under ICD-10. Also, how is it measured? From patient care generated by medical record documentation. So there's a lot of reporting that comes right from your EHR. So, I asked the question, who has been involved in setting up your EHR? Has there been coordination across departments for documentation needs? Here's where you don't want to run into duplication, maybe, of needs or services. So it's important that you have your team focused on looking at that medical record EHR. Your cost and charge data is also how you're being measured. So here you ask the question is, how have you set your charges? There's a whole initiative here on pricing transparency right now as we look at the initiative that they're looking at cost per patient. And basically that's all being driven by your charges. So you really want to make sure that you have an appropriate charge strategy set up in your facility as this cost per patient begins to be being looked at. And then patient surveys. And again, those are a little bit out of our control as we are subject to the interpretation of the patient in their evaluation of their stay. So who's looking at the data? We know that our payers are looking at the data, Medicare administrative contractors, our MACs, the OIG, state agencies, our quality improvement organizations, RACs and other regulatory audit agencies, healthcare facilities, beneficiary and patients, CMS obviously. So basically everyone is looking at the data. And for those of you that have been involved in different types of RAC audits, we know that everybody's data mining. It's easy to do, to access the claims data and, start to do analyses on it. So everyone's looking at the data. So when we look at value-based purchasing, the quality measures used for that value-based purchasing fall into 4 categories. This is from the hospital perspective. So this is how you're kind of evaluated. So we're evaluated on our process measures. So for example, those are things like were antibiotics given in the appropriate time? Did a patient receive their discharge instructions? So those are types of process measures. There's also outcome measures, and those are the items that you report for those, I think there's 12 of them now: acute myocardial infarction, heart failure, pneumonia, 30-day mortality. There's some patient safety ones. So those are where we're looking at measuring the outcome of a patient's stay. There's also the patient experience, so that falls into those surveys, and those things address things like the nursing communication, the physician communication, pain management. So those are centered around patient experience. And then the last one is on structure measures. And those are basically features of a delivery system within an organization and capability of the staff. So those are things like, can the provider prescribe electronically? You know, do you have e-orders? Things like that from a structural standpoint. So that's how, those are the categories of what falls into this value-based purchasing. So this particular slide is actually the Medicare goals of value-based purchasing. And I thought that they were interesting to kind of take a look at. So the first one is, the first goal of Medicare is for financial viability. So they want to ensure the traditional Medicare fee-for-service program is protected. The second goal is payment incentives. So they want to link payment to the value, the quality and efficiency of care. We've talked about that. Also, joint accountability. Here's where providers share clinical and financial accountability for health care. So here we're seeing where we're moving more towards bundled types of payments. And actually there was something that came out this week that CMS is going to be testing bundled payments for hip and knee surgery. So there are different options for bundled payment services. Some of them include where they would bundle the hospital and physician payment together. So in that instance, that kind of falls under this joint accountability, because it's going to be up to the physician and the hospital to work together in order to ensure that the costs are lower when what that bundled payment will be, because they will just receive one bundled payment. The hospital won't get a separate payment and the physician won't get a separate payment. You get a joint payment, so you have to work together. Also, there's effectiveness. So they want to make sure that care is evidence-based and account-driven to better manage diseases. They want to ensure access to, so basically ensure access to high quality and affordable care. They talk about safety and transparency. So beneficiaries receive information on the quality, cost, and safety of their care. So again, this is based on data. And I'm sure you've all been seeing the star ratings that are happening. 5 stars is good, 1 star is bad. So all of these programs are starting to have some form of star ratings within them. Also, they want to ensure smooth transitions, so payment systems support well-coordinated care across provider and settings. And then finally, improved technology, where your EHRs help providers deliver high-quality, efficient, and coordinated care. So all of you who have been going through an EHR conversion, we know how difficult that is. There are still a lot of hybrids out there. Sometimes the EHRs may not be working optimally. So we definitely need to keep moving towards better and improved technology. So there are various healthcare, or CMS basically, these are the CMS Medicare types of quality initiatives. So it started, and we have our hospital value-based program, the hospital inpatient reporting quality program, the hospital readmissions reduction program, the hospital acquired conditions reduction program. We have the hospital outpatient reporting program, the physician quality reporting system, our PQRS, which will soon be being moved to what we call MACRA and MIPS and all of the new acronyms. We'll talk about that a little bit later. We have an ambulatory surgery center quality reporting initiative. There's the inpatient rehabilitation facility quality reporting program. There's one for long-term care. There's one for PPS exempt cancer hospital quality reporting. There's inpatient psychiatric facility quality reporting program. Home health, that one is kind of just getting started. Hospice has its own, and then the end-stage renal disease quality initiative is also starting to move. So you can see these alone are just the CMS ones. So obviously other payers may be doing them as well. So it's important to understand, which of your payers are starting to tie this quality into some form of payment for you. So we talked a little bit earlier about profiles and quality scores. Here's a list of a few examples of reporting agencies. They report both facility and physicians are basically profiled. And here's where you can go in and look up a particular hospital to see how they're being ranked, and then from an individual physician perspective too. So it would be interesting to know how many of our listeners today have actually gone in to look up your particular organization or facility to see what you look like. Maybe even have you looked up your own personal physician, or if you were looking for a particular physician to go to, have any of you gone in and looked at and seen what their scores are? It's kind of interesting if you haven't done it. So here's an example of health grades. This is a hospital that shall remain anonymous, but it is an actual hospital. And these are some of the items that it shows from a quality perspective. And you can see where it breaks it down to worse than average, average, or better than average. And so everybody's goal is to be in the better than average category. So when you look at some examples here on this page, death in procedures where mortality is usually very low, they're average. Pressure sores or bed sores acquired in the hospital, they're better than average, so that's very good. But this next one, it shows death following a serious complication after surgery. So if you were going or needing to have surgery and you saw this, it might make you question whether or not you would want to go there. Now, what this particular X means, was this a really sick patient who had surgery and unfortunately passed away? Was this a young patient where nobody, where it was an unexpected? This is where the data, you don't really know what's behind the data. So it's all subject to interpretation, but that's where our challenge is, I think. So a couple more of these on here: collapsed lung due to a procedure or surgery in, around, or the chest, and then our catheter-related blood streams are all looking average. So when we move on over here, again, better than average on a few items, average on a few, but if you look at the bottom, foreign objects left in body during a surgery or procedure. They had 3 events. Now, what does this mean? 3 compared to what? How many procedures does this particular facility do a year? This could be a very non-statistical number, or it could be significant depending upon, what's going on there. But one thing to keep in mind here is that codes impact these scores. And do your coding staff know this? For those of you out there who are involved in the health information management area, do your coding staff know that their codes impact this? And so is there an understanding from their on their part about coding complications or things like that? So we'll take a look a little bit later in this webcast about some processes to help with this. Here's an example of a report from Health Grades on a particular physician. Again, the name of the physician is anonymous, but it just goes to show you that there's a lot of information out there now, and that everyone has access to some of this data, both from your facility or practice perspective. and you should be looking at your data on a regular basis so that you can see how it's looking. So we're going to talk a little bit here about severity of illness and risk of mortality because these are two primary items that really impact severity scores both on the hospital and on the physician side. And it's important that the physicians understand this, as it's not just reporting from their own practice, but hospital inpatient stays. That diagnosis information does reflect back on those particular physicians. So for those of you that aren't maybe familiar with APDRGs or APRDRGs, within the DRG system, our options are really, with a CC or MCC or without, with some combinations there. So it's a fairly structured measure for typical resources of the patient, but you have one chance basically to increase your DRG. From an APDRG perspective, that's all patient DRGs, and these are similar to a DRG but include more detail for newborns in clinics. And then there's where we've progressed to the APRDRG system. These are all patient-refined DRGs that actually include severity of illness, risk of mortality, and resource utilization is all taken into account. So basically how this happens is all ICD-9 codes, and of course soon to be ICD-10, have established severity of illness and risk of mortality. So, for every code, there's a rating of 1 to 4 for minor, moderate, major, or extreme. So once all the diagnoses and procedures are coded, it's a complicated algorithm that's used to then determine the APRDRG severity of illness and risk of mortality scores for the patients. So it's kind of like your DRG grouper, but it's an APRDRG grouper. And the combination of diagnoses impact the score. And you never really know what's going to impact because everything impacts. I mean, something as minor as like a smoking history, which isn't a CC or an MCC under DRGs, but it does impact severity of illness, risk of mortality. So here's where it really starts to break down. So basically, CMS uses these scores to determine the average severity of illness and risk of mortality for patients of a hospital or physician. So again, they data mine whether you're paid based upon an APRDRG or not. Some states do have some APRDRG payments, some don't. It kind of varies depending upon the payer. But CMS is still using this data for this information. So then what happens is once that they've calculated these averages for severity and risk, CMS determines the mortality index based on risk adjustment to determine the ratio of actual deaths to expected deaths. And then the MSDRGs have a geometric length of stay, which can be compared to the actual length of stay. So here's where they're taking everybody's data and averaging it out. So again, the data needs to be good so that it averages out right. So always remember, too, that we're always 2 years behind in the data, but your data is impacting decisions that CMS makes. So again, you want to make sure that it's accurate. So just a side note here for a second, since we are so close to ICD-10 and October 1st, think of the first year of I-10 data, and are you prepared? So, we know that there are still issues with I-9 coding. Here we're going into a brand new coding system. We know there's going to be a learning curve. So do you have an aggressive auditing plan set up to avoid errors? It's not really just about, is my DRG right anymore? It's how does that coded data impact quality and reimbursement? So we'll talk a little bit more about this later. So basically, the higher the severity of illness and risk of mortality scores, the more it supports the medical necessity for admission and longer lengths of stays. So here's how you support longer length of stays and higher cost claims is by having diagnoses on your claims that show severity and risk. So then each MSDRG has a relative weight, which reflects average hospital resources used to treat the patient and then it establishes reimbursement. And then CMS is able to actually compare actual costs to expected costs. And I mentioned earlier, if you remember, the cost per patient quality initiative. And here is where that charge strategy fits into it, because they basically, starting this year, 2015, are going to be looking at the cost per patient and, again, comparing everybody. So, again, what is your charge strategy? What are your charges? What does it cost you when you start to be compared to other facilities? And a lot of places are really starting to look at their pricing strategy, and basically they're calling it pricing transparency, basically. So relative weights then are also used to determine the Casemix Index, which is another way to reflect how sick your patients are. So this data is used to profile, like I said, both the hospital and the physician. And so when the patient's severity of illness and risk of mortality is not accurately reflected by physician documentation and a poor outcome occurs, it appears as though complications are occurring in healthy patients. So this is why it is really important to ensure that the most specific codes are assigned. And this could be an issue under ICD-10, because as we find in doing our audits, while you can usually assign a diagnosis code, a lot of times we're finding an increased use of unspecified codes. So here's where, through your audits right now and assessing of physician documentation, you really want to start doing some data analytics on the types of unspecified codes that are being assigned and seeing where you can drill down to work with your physicians and your CDI staff, work with them too, so that they can work with the physicians to address if you have a high utilization of unspecified diagnoses. And this is also true not just in the inpatient setting, but in the outpatient setting, because we will be reporting I-10 diagnosis codes. And, you know, that's another issue, too, related to your medical, your LCDs, your local coverage determinations, and your NCDs, your national coverage determinations. What are they going to look like when they're converted to ICD-10? And you really want to make sure that you're looking at those ahead of time so that you are prepared to know how those have been rewritten and if there's any impact at your facility. So here's an example of what severity and risk of severity of illness and risk of mortality scores look like, or not the scores, but the rankings when we talked about the 1 through 4. And the clinical documentation here, these are terms that are often used by physicians and can be used interchangeably from them. We know that physician language and coding language do not see eye to eye. So sometimes it's just what the physician wants to use for language versus what we need for coding. And you can see that just by, if the physician writes acute renal insufficiency, that has a low severity of illness and risk of mortality score. It gets a 1 and a 1. Versus if the physician is documenting acute renal failure or acute kidney injury, that's showing a higher level SOI and ROM of 3. So this is why it's important to make sure that we're addressing that specificity. And there's a lot of hospitals now that are, while they may not be paid based upon an APR-DRG, they actually have their coding staff utilizing the APR-DRG when they're coding in relation to looking at severity of illness and risk of mortality. And a lot of the CDI staff are using this now as well to try and determine when a particular condition may impact a severity score. So severity of illness and risk of mortality impacts your case mix, your mortality rates. It can impact contract negotiations, You want to try and stop MSDRG reductions. If you're negotiating payments with particular payers, again, over time, if you're showing less acute patients, they're going to want to try to negotiate for paying you less. So is it true that you have less severe patients, or is your data just not supporting it? Also, from improved E&M professional fee arrangements. If you're a physician or if you're a facility or a health system that employs physicians, again, you want to be able to support and negotiate payments for those E&M services. Looking also at quality data metric reporting for medical necessity. You want to be able to negotiate the best contract, and you can only do that when you know that your data is accurate and you have the documentation to support the reimbursement or the payments that you're requesting. It also helps to validate the care delivered, obviously. We're hoping that it will do some prevention of random audits by regulatory agencies. Again, in their data mining, it's all about how the data looks. If you're showing, acute, severe patients, and you have a high charge or a longer length of stay, that may be something that they pass over because, again, the data is kind of making sense. Well, gee, this patient's really sick. Maybe they look at the age of the patient, they're older. It kind of helps to support and maybe helps to reduce the number of audits. And then obviously from that value-based purchasing perspective as well that we've been talking about, where you really need to be showing improved outcomes. It's all happening from that severity of illness and risk of mortality perspective. So let's talk a little bit about the impact in the provider and the impact of the provider setting. So issues that impact data, quality data and financial performance, obviously part of our theme today, incomplete, ambiguous, and or clinically incongruent documentation, incorrect or incomplete coding, sequencing of coded data, understanding the complexity of severity of illness and risk of mortality, and then conflicting documentation requirements to providers when we're looking at coding versus quality versus clinical definitions. So here's where there can sometimes be a difference in opinion as to, clinically what is wrong with this patient versus how does that data look when I transform it and report it for quality, and then how do I interpret it and code it? Sometimes that coding and quality, it doesn't match up. You might code something because of a coding rule, but then it has a negative impact on your quality. So kind of how do you handle all that? And this is where you really want to be making sure that you're looking at this. And we're going to talk a little bit about this later on when we talk about some recommendations, for looking at processes and whatnot. But it's important now to know that coding is not just coding anymore. It takes time to do all of these components, and then you want to, for next year, next couple of years probably, add on the I-10 factor into that for productivity impact. And you really need to start addressing staffing in that particular coding area, because a lot of this financial payment and quality ratings are tied to that coding. So you really want to make sure that you are doing that appropriately. And something important, too, to make sure is that you're addressing, especially going into I-10 and the whole data conversion, that you've done your education with your staff, that they're practicing, that you're auditing, providing immediate feedback, and providing supplemental education. And this should be happening well into 2016. Here, this is just a little kind of circle, as I like to call it, that kind of shows how one feeds into the other. So everything starts with the physician and other provider documentation. Clinical documentation improvement, works on that concurrently while the patient is in-house writing queries. Then typically somewhere in there we have our quality measures data collection. Here I've kind of stuck it in this spot, not really knowing from facility to facility where it might fit in. But the thought process of this circle is that if you move on from that for just a second, you can see the HIM potential retrospective query and final code assignment, and then it goes to DRG assignment severity of level. But my point of this circle is, where in the process does your quality data come into play? Because when that patient is discharged, the record may still be incomplete. There could be missing documents. There could be retrospective queries that the coders want to do. So if there's quality data being collected based upon any coded data, are they waiting for that record to be complete? These are things that you want to make sure that you evaluate, and we'll talk about that a little bit later from a process perspective. So more issues that impact quality data and financial performance. So lack of coordinated system for flagging, reviewing, and correcting quality concerns. So if you find an issue, how is that being addressed? What we've been finding is that, like I said, kind of quality right now in organizations can be a little bit disjointed. Where they report to, which departments, what are the department names. So here's where we need to start to get a handle on, what is everything within our organization. Also, lack of knowledge by team members related to coding and quality definitions. Has staff really been educated on what all of this means? And then identification of issues retrospectively resulting in compliance risks. So are we waiting till something gets rejected or the patient is discharged, or, how are we addressing potential discrepancies in data before we start reporting things is kind of basically what I'm talking about here. So again, we'll talk about some potential recommendations later. So let's talk a little bit here about the 2015 financial impact. And here's where, I'm still learning a lot of this too as I share this with you and have moved into kind of this side of the industry. But we're going to just view from a high level, try to share with you some of the impact that it's having or will be having from a payment perspective. So as pay for performance moves into high gear, significant updates have been finalized. So for fiscal year 2015, that's this year, this marks the first year that 3 pay-for-performance programs, which is the value-based purchasing, the readmissions, and the hospital-acquired conditions. So these are all inpatient initiatives. They will apply for inpatient payments, and collectively these programs place about 5.5% of inpatient reimbursement at risk. And predictions are showing that only the VBP portion having any really potential for good performance. And this was taken from an article from the advisory board, and this is their business in determining these types of performance impacts. So just a little bit of history or perspective here. So the hospital, the VBP program, those are those 12 measures. So those are the items that we talked about earlier, like the acute myocardial infarction, the heart failure, the pneumonia, the surgical care complications. Those are the items that make up the VBP system. Readmissions, that's self-explanatory. That's the number of readmissions that you have, and then your hacks are self-explanatory too. So based upon that program, remember that we talked about the 4 incentives that is based on that. That's clinical processes, patient experience, outcomes, and efficiency. So the clinical processes is based upon about 20%, the patient experience about 30%, outcomes 30, and efficiency 20. And we're actually expecting that some of these percentages will change as we learn more about which are better indicators of success within the program. And I will say that we're actually, VBP Monitor is doing a series of white papers on this right now. So when you sign up to be a subscriber of VBP Monitor, which is a free service, you can actually download and receive these white papers for free, which we are beginning, again, like I said, to assess, is the data really working? Is it showing what it should be? So this is how those programs are kind of broken up right now. So from the hospital-acquired conditions reduction program, acute care hospitals that report the most hospital-acquired conditions will see Medicare reimbursement reductions of 1% this year. From the readmission reduction program, so of the 3 P4P programs, the readmissions penalties are the most significant for inpatient payments. In 2015, hospitals could lose up to 3% of reimbursement moving forward due to readmissions. So again, this is also taken from an advisory board article. Here's a little grid that kind of shows what we just talked about a little clearer. And basically, it's showing the potential reimbursement impact from 2013 to 2017, the percentages associated with each of the 3 programs, and where you are at risk for lost reimbursement, and how much of that. And trust me, your CFO understands this. For some of us lay people, it can be a little confusing, but your CFO folks are understanding the overall impact. So for this presentation, we're kind of focusing these 2 slides really on the inpatient program. But remember that there are a lot of other types of programs out there. So in fiscal year 2015, general acute care hospitals will see a 1.4% rate increase if they successfully participate in the hospital IQR program and are meeting the meaningful electronic health record users. So hospitals that do not successfully participate in the IQR program and do not submit the required data quality electronically will be subject to a 1/4 reduction of their market basket payment. And that, I guess, equates to about a 2% point reduction. So again, these get a little bit financially technical, but again, your CFO understands this impact. So currently, the hospital IQR program includes the following items, and this is kind of going to summarize what we've been talking about. So it's those chart abstracted measures, such as heart attack and the surgical care improvement measures, claim-based measures, such as mortality and readmissions, healthcare associated infections measures, survey-based measures, such as patient experience of care, and those structural measures that assess features of hospitals to assess their capacity to improve quality of care. So again, you can see that there's a combination, abstracting information out of a chart, taking information from claims, reporting items by codes like the infections, surveys, and structures. So it's really tying in all aspects of care, basically, and services. So to talk a little bit about the future of value-based purchasing impact, this slide is really significant for us all. So if any of you are familiar with this, so the Department of Health and Human Services announced this past January a new set of goals and a timeline for tying Medicare payments to quality or value through alternative payment models. So one part is to tie 30%, which is up from 20%, of traditional Medicare payments by the end of 2016, that's the end of next year, through ACOs, which are our accountable care organizations, and bundled payments. And then increasing that to tie 50% of that by the end of 2018. So also then, HHS also set a goal up of tying 85% of all traditional Medicare payments to quality or value by 2016. Again, by the end of next year, 85% and 90% by 2018 through these programs like the hospital value-based purchasing and hospital readmission reduction programs. So you can see this is a really aggressive program to look at alternative payment methodologies. So this little grid, which I borrowed, you can see the reference down below, I think gives a really good visual for us of what this means. So if you look at last year, 2014, so the gray shaded area is all of Medicare fee-for-service. And then the kind of medium blue is the fee-for-service linked to quality. And then the blue circle within that is that 20% of that 80% needs to be tied to alternative payment models. So that, again, is where we're looking at ACOs and bundled payments. You can see how it progresses in 2016, and then you can see how it progresses in 2018. So that's a really huge jump to be tying that much of an increase in that short period of time. And there's actually a lot of discussion in the industry right now about whether or not we have the infrastructure to support that. You know, part of putting all of this together is making sure that we have the infrastructure to report it. And we actually have a really good article this week on the homepage of VBP Monitor that's called "How Close Are We to Population Health?" So if you go to vbpmonitor.com, you can read that article, and it's a really interesting article on and perspective on this whole concept of are we there? And we'll be continuing, obviously, to cover this as it continues to move. So also we'll switch a little bit here to the physician side of things. So this past, earlier this year, I guess, passage of the Medicare Access and Ship Reauthorization Act, what they're calling MACRA. This is what's going to be replacing the PQRS, which basically permanently repealed the Sustainable Growth Rate formula, the SGR, for physician reimbursement in the Medicare program. So basically, there's two provisions of the legislation that have attracted attention, which include the merit-based incentive payment system, which is MIPS, and support for transition to alternative payment methods, which they're calling APMs. So beginning in 2019, bonuses will be available for eligible professionals who score well in MIPS, which will become the new pay-for-performance program under the Medicare system. The current penalty calculations under the PQRS system for electronic health records, meaningful use, and the value-based payment modifier, VBM, would end at the close of 2018. So what replaces that then is MIPS, and MIPS will gauge program performance based on 4 categories: quality, resource use, meaningful use, and clinical practice improvement activities. So basically, they're going to take the several separate physician programs and consolidate it basically into one. And so when you look at the quality aspect of that, 50% of the total adjustment will be in 2019. And then that will be shrinking to about 30% of total adjustment in 2021. And then they vary throughout. But the goal here, though, is to shift from PQRS to this single newer form with different incentives. And the options for payment change over the course of several years. And then there's also, when we take a look at it, the adjustments also range in 2019. They could see adjustments from a negative 4% to a positive 12%, and by 2022 from a negative 9 to a positive 27. So even from that physician side, you know, this is significantly moving to impact reimbursement. So MIPS is basically intended to build upon and improve current quality measures and concepts in effect now for PQRS, MU, and VBM. The next step will be the publication of the regulations on the details of how MIPS will be implemented. MACRA also provides incentives for physicians to develop and participate in new models of healthcare delivery and payment. Professionals who receive a significant share of their revenues through an APM are slated to receive bonuses each year from 2019 to 2024. And those are the percentages that I just gave you. So there is a controversy, obviously, with this, and it's always interesting to continue to hear and read about the debate on how all this is working and how it will work. So that's a little bit about some things that are happening on the inpatient side and the physician side. So let's remember, though, that there are a lot of other quality initiatives, too, depending upon where you are. So what should we do? So it's important to make sure that we are knowing what we can do now to start impacting some of these decisions in the future. So you want to know where your hospital stands on each selected measure for the baseline period and identify which measures have the best rate of return, and understand how discharge volumes by measure factors into your VBP score. So it's basically know your winners and losers in your quality reporting. Also, you want to ensure that your pricing is competitive, especially in the outpatient market. So this we talked a little bit already about, but you want to look at, and you want to look at all, a lot of folks base their payments or their payment structure, charge structure, I guess I should say, on Medicare. You have to be so much above Medicare, or, let's do a percent aboard increase. And those are really dinosaurs now, I guess, for lack of a better word, when thinking about how to build a charge strategy, because you really need to look at all of your payers, all of the reimbursement initiatives, and really look and calculate and make the right decision on what charges should be. So it's definitely, your pricing is something, if you haven't done it already, to certainly address now. You must obviously have C-suite buy-in, and this really needs to be led by your CEO so that folks really get engaged in this and take it seriously. You want to have a multidisciplinary team approach to it. Clinical, quality, financial, HIM, IT staff all need to be working on this. Sometimes we can be a little territorial, I think, when it comes to some of this stuff, but you definitely need a team working on this. You also want to promote a culture of transparency and integrity. People need to know what's going on. And then the two important areas to address from a clinical data perspective, you want to make sure that you're looking at documentation, your CDI program, and your coding. And then from a technology standpoint, so much of this is tied to technology, so your IT department, your EHR, your data reporting templates, you really want to make sure that you've addressed those areas as well. More strategies, you want to assess inefficient areas of the hospital, so you really should do a process analysis of where all of your quality data is being processed, who's doing it, how is it collected, where are they getting the data from. Really do a process review, and then see where you have overlap, duplication of services. Are you missing something? Did something fall through the cracks? It's really important to do that. Cross-organizational governance too. Again, here it doesn't matter who does it and whose territory it is. You want to work together because there's pieces that come from all over. We talked about IT involvement is critical. You want to invest in comprehensive data collection and reporting systems. You want to ensure that you're addressing patient satisfaction. And you want to be sharing quality scores both from a hospital and a physician perspective. It's important that physicians understand their quality scores. And we're actually doing a lot of audits right now just on that, looking at documentation and working with physicians individually, showing them where their quality scores are based upon the documentation they're giving us and what can be coded versus what could be coded if they were more specific in their documentation. And the doctors are really kind of catching on to it and really starting to cooperate. Also, you want a review of all reporting and audit mechanisms to assess for duplication of efforts and conflicting messages. So I mentioned that briefly. Here, too, is when you find you have discrepancies or conflicts between, I kind of talked about the example where maybe HIM codes a complication and then that impacts quality reporting. Well, where's the gray line there? Was that really a complication? Was it not a complication? Does coding understand what they're doing? Does quality understand that there's a coding rule? Here's where if you could identify certain quality items or diagnoses or procedures that you might want to review before you bill it or before you report it, and have someone kind of take a look at it overall and then process it through. So here again is where you can look at your processes for identifying potential issues before they go out the door and address them up front. Let's see, focus review of cases with quality issues by an external auditor. It's always good to get an outside look at things, just like you do your coding audits. Development of a multidisciplinary task force to develop workflow and shared processes with a single point reference for providers. Here, too, is something to think about. Sometimes we have a lot of different staff approaching physicians. Approach them? Does quality approach them? You know, maybe they all approach them, but you need to assess and analyze and make sure that their processes are right and that there's not overlap and that it's making sense. You want use of a quality tracking tool, so you want to make sure that you have that. Determine problem, quality issues, and develop a focused corrective action plan. So as you do your assessments and you find a problem, you want to address that and make an action plan to correct it. And again, you want to use your entire team for that and get everybody involved. Education for the entire multidisciplinary team, again, making sure that everybody understands both, you know, all the different sides of what's happening with quality reporting. You also want to run, use, and share reports and look at your data. You know, look at your severity of illness data, your risk of mortality, your patient safety data, length of stays, readmissions. These are just a couple of examples. There's probably a million more that you'll want to look at. But who's looking at the data? Are you sharing it with the appropriate folks? Really looking to see how you can communicate positives and opportunities where you might be able to improve on data collection and reporting. So accurate clinical documentation impacts coding, as we've talked about, severity of illness, our risk of mortality, our present on admission and our HACs, hospital-acquired conditions, our Casemix Index, core measures, patient safety, outcome measures, profiling, compliance, audits, and so much more. And, you know, we're kind of focusing right now on that clinical documentation, and it's important, I think, to be looking at that CDI program. Again, depending upon how your organization is set up, what quality might be responsible for. We're starting to see quality departments, and you know, some of it still fall under HIM, some going to quality. We have CDI, but again, kind of looking, as I said, to look and see if there's crossover, and if you don't have the luxury of having, you know, a separate quality staff, how can you utilize your CDI? And there are a lot of CDI programs that are really starting to tie into the quality initiatives and looking at that documentation or lack of documentation during an inpatient stay, and working with the physician from a query perspective while that patient is in-house. Again, trying to minimize multiple people or multiple staff contacting the physician, you know, talking different language, asking them for different things. If you can consolidate that to your CDI staff, get them educated on the quality stuff, determine what you want them to focus in on, educate them on that, and have them work with the physicians, I think that that would be a really good utilization of their time. And like I said, it obviously will impact their productivity. You may have to look at staffing there, but the payoff, I think, will be very beneficial to you, as you can see how all of this data, you know, it starts with the documentation to support what your coding staff is going to assign. So the more comprehensive the data, and the more you can gather that concurrently while the patient is in-house, it doesn't delay the billing process on the back end. So something to consider. So here from a CDI program, it should be reviewed as a necessary aspect to the provision of patient care and overall operational performance, which would result in higher quality patient care, better treatment outcomes, higher quality scores and reporting, better patient safety indicator scores, accurate reimbursement, both from the facility and the physician side, especially for hospitals that employ physicians and you're billing for those services. It's also going to help sustain your CMI and hopefully decrease recovery, audit, contractor, and RAC denials. So we're, again, with the hope that by reporting better data and data that makes sense when it's looked at in a whole, hopefully it will reduce records that would get targeted for audit because the data can show and support what you're reporting. So the role of the medical staff, that's important here. CDI activities must resonate with all clinicians as an organization strategy critical to the longevity and survival of the organization. I know I just was talking to somebody, and somebody said that one of their physicians basically said, well, once ICD-10 is implemented and the CDI will go away. And that's definitely not the right attitude to take because I really do think that CDI is here to stay. Again, we don't want our physicians to have to learn, coding or know all the ins and outs of documentation that they need. Here's where your CDI staff can work with the physicians, and help them. So I think the CDI department is basically going to be around for a long time. The physician concurrent query process is the core operational component of every CDI program. And the key here is timely query response. So again, depending upon your CDI program, how much it is supported, really monitoring the response of our physicians to queries that we're asking them. And if physicians are not responding, then CDI needs a place to go to in order to have support from administration, from the C-suite, probably the medical staff, advisor, to really help to support the need for completion of these concurrent queries. And also if any of the retrospective queries are coming in, if something is found after discharge because of some additional documentation. And then again, looking to see if you've added quality to your query process. So good documentation basically saves time and money and improves communication among providers as well as the overall quality of care provided to the consumer. So it really does pay off in the end, and I think as you start to improve your processes. And there's been organizations that have been working on this for quite a while, and they have proven the impact, both from a quality perspective, as that's always our #1 goal, is the improvement of quality. It helps in the coordination of care, and then it also definitely has paid off in the reimbursement aspect as well. So to wrap up this portion a little bit today, so recommendations for a CDI program. A CDI program's objectives is you want to improve the MSDRG assignment to sustain Casemix Index and prevent erosion due to regulatory changes. You want to improve severity of illness and risk of mortality classifications. I can't stress that one enough, especially if your organization hasn't started to look at that, both from a CDI perspective and from a coding perspective. Making sure that we are documenting, that our physicians are documenting our conditions to the most specificity, and that we're looking at how they are impacting severity of risk, or severity of illness and risk of mortality scores. And here's two where you want to address your query process. Obviously we don't want queries to increase so much for physicians that they get overwhelmed and they don't want to answer any of them. It really is up to you all to strategize and determine what you want to query for, And as physicians improve, then maybe perhaps you move to your next layer of things you want to query for. But you really should strategize and make some determinations on what you will and won't query for. Also, objectives are to maintain high-quality clinical documentation, which we know. It needs to support internal quality initiatives, report valid and reliable data, influence external quality measurements, and support the implementation, obviously, of ICD-10. So I think with CDI working optimally, it can help to support quality related to this presentation today, value-based purchasing, all the programs that are happening, and as a side note, since we are so close to ICD-10, you know, help to support our progression into the implementation of ICD-10 on October 1st. So I like to just close this out with one quote, and it says, "And then the documentation is gone, and all that is left is a set of numbers." So basically, what people are data mining is looking at those numbers. They can't read the note to see how to interpret the data. They just see the outcome of the numbers. So again, it's so important to make sure that we are reporting the severity of our patients to support the resources that we are consuming. So with that, I'm going to turn it back over to Maria.
Hey, thanks, Kim. Great presentation. And before we get any further, I want to turn the controls over to Rayon Kishba, who is going to show our solution. Ray?
Hi there. Can you see my screen now? No, it says
Ray Ellen?
Hi, can you hear me?
Now we can.
Okay, great. So I just want to make sure that I'm sharing my screen properly.
I don't see anything yet, Ray.
Okay. People see a paused version of my screen. Let me see how I fix that. Now, can you see my screen? Oh.
And I am trying to switch you over, but it looks like you have control.
I do have control, and it looks like I'm sharing. Let's try that.
Now we see it. Perfect. Thanks, Ray.
So thank you very much. That presentation was fantastic, Kim. And I just want to think about some of the ways that we can use our existing tools to sort of stay on top of this. So I wanted to just demonstrate two quick things from the regulatory perspective. If you have a MediReg subscription, you can actually do some searching in the system. And I might want to search for just that acronym VBP, or maybe the phrase value-based purchasing. And I'm not sure if it's, you know, they might end it with something other than an ING, so I can search for a phrase, that little star. And you can see in my subscription I have access to court cases and OIG reports and Medicare regulations. And I'm just going to run that search so that I can see everything that's been published in the past talking about this fairly new concept. If you feel like you've already fallen behind, it's probably because you're paying attention and you missed a lot. And then if you have a MediReg subscription, I just want to indicate that you can store this search so that the next time a new piece of information comes out, we'll send you a personal email alert letting you know about this change. And so as you educate staff about this issue, you don't necessarily have to reinvent the wheel. Being able to utilize some handouts, fact sheets, things like that that CMS has published can be very helpful. I also, in listening to you speak, I realized there's just so many changes happening in the inpatient world. And where that change is discussed is in the proposed rule in the Federal Register. And looking at that in the Federal Register can actually be quite cumbersome. It's a big newspaper, and it's many, many, many pages long. So I want to show you that under our CFR and FR search, we give you access to e-book versions of those rules. And so this has the proposed rule for 2016 in here now. And of course, when the final rule comes out, we'll put that in the same location. It also gives you access to the downloadable files that CMS posts on their website. Often sort of the justification for the proposals that they're making is really deep in the data. And so this tool right here will allow you to search across the proposed rule, the final rule, any corrections, as well as all those data sets. And then you can see when I open the folder, it's a really nice browsable ebook. And even before I dig in on this, I just take a few minutes to open and close and see what the hot topics are just by reading the headings. And then I'll find myself really doing some deep research in there. And if I want to see all the discussions of VBP just inside the proposed rule, there I am finding that information. I think that's pretty handy. And then next I want to show you a tool from MediRegs and New Health Analytics called the MSDRG Analyzer. And this tool allows you to calculate provider or state or national averages for MSDRGs. And it really helps to highlight all the various variables that are impacting payment. And I'm doing a comparison report here. It's a lot on screen, but let me just have you focus all the way over on this left-hand column first. I'm looking at DRG 470, and I'm looking for national unadjusted information. And down here I can see that that major joint replacement DRG on unadjusted at the national level would be about a $12,000 stay. And I can see that broken down into operating and capital using just the standard multipliers that are published in the Federal Register. Now let me scroll back up. The analyzer also lets me set this by a geographic region. So in the second column where it says Maine and there's a number 20, this is an average of the reimbursement for this date, for this DRG, for all the hospitals, 20 of them in Maine. And so I can see that Maine is, on average, being paid about 22% more than the national unadjusted. And you'll notice down here, there are these extra columns, these rows for uncompensated care, readmissions, value-based purchasing, and the low-volume add-on, as well as the hospital-acquired condition adjustment. And so I'm seeing state averages, and I can benchmark against that if I want. And then I just, looking at the value-based purchasing tables that were published on the Quality Compare sites, I picked a couple of organizations just to show in a really concrete way some folks who are winners or losers on the VBP adjustment. So without paying so much attention to who the individual providers are, let's just take a look at these columns 3, 4, 5, and 6. And again, they're all marking themselves as a benchmark against that national unadjusted. So green means more and pink means less. You can see the little percentages as well. But let's just take a look across just the VBP row. You know, this organization on one particular stay, a $21,000 stay, is losing $200. Here's an organization losing $150, and then it can go the other way as well. Here's an organization gaining additional revenue because they're doing the value-based purchasing reporting properly, and then here's an even bigger winner. And what we really want to think about in terms of the financial impact, I love that slide that you gave us, Kim, where you could talk about overall the hospital's impact might be impacted by 5.5%, including these various, and it's nice to sort of see where it goes up, where it goes down, and what the impact of our specific organization is. And I also just want to point out that if you use the analyzer, you can scroll down, and we've really taken the mystery out of the PC Pricer, which might be a little ugly little tool that you've downloaded from CMS. So here are all the variables for each, you know, national, state, or each of the individual providers. And the ones that are dashed, you can actually change those numbers. So if you wanted to do an analysis of your organization, and you wanted to prove to somebody that if we fixed our variables, we did our reporting better, we might change our revenue, you can actually just change your numbers here, and we'll recalculate for you and show you what that adjustment would look like. And we do keep this up to date with the pricer. One other thing I want to show you that I just think has been really compelling and also quite confusing is that Medicare updates the pricer quite frequently. And so this is according to what I've just run here as a query for a given provider and a given DRG, and I can see the reimbursement rate. But I can also, instead of looking by a specific discharge date, I can actually take a look based on which pricer hub updates we've performed. And as that pricer is republished, we see CMS sneaking in corrections. Sometimes those corrections are even retroactive. So even if you've done all your reporting properly and you're getting paid, those numbers may change unexpectedly. And you might want to be able to pull reports on that so that you can go to your payer and say, gee, you know, we filed a claim and then retrospectively CMS adjusted the pricer. Could you please give us an adjustment? And so I'd love to give you a little bit of a deeper dive into this tool if you're interested. We can follow up after the call today. Now, Maria, I think you have some questions that have come in through the question and answer panel. I don't know if I should give presentation control back to Kim in case she needs to refer back to one of her slides. But I'll do that now, and then maybe you can just let us know what the questions are.
Sounds great. So everyone, feel free during the last 10 minutes of today's call to enter questions to the right of your screen. It is, as Kim had alluded to earlier, we're all learning on a day-to-day basis, and regulations are changing as we speak regarding VBP. But we do have one question from the audience, Kim, that says, can you please cover VBP from a physician perspective? Is the first question, and can you talk a little bit about that? And then the second piece is actually pretty loaded in that the second question is, how does the 1-year ICD-10 transition period agreed to by CMS and the AMA affect VBP? So there's actually 2 questions there. I know, they're loaded.
Okay, well, I don't know how much detail I can get into them just because they are kind of loaded. I can maybe try to put something together, a little bit, after the fact, maybe send some, forward some information or some, references and whatnot. But as far as the impact with ICD-10, I don't know that we know yet. I mean, I think some organizations have done some analysis. Like I said, AHRQ and HEDIS has done some articles I've read from them where they've done some internal audits or studies themselves on the quality items that they have that people report to them on, and it's basically showing that there's not a lot of discrepancy in the data. Again, I think like anything, we want to wait and see what happens. So from an I-10 perspective, I don't know that we know yet what's going to happen there. And so then from the physician perspective, I mean, right now, the value-based purchasing initiative basically is your PQRS. And basically that's, it's a combination of your EHR, if you were participating in the EHR reporting and some of the quality initiatives there. And so what we talked about was that, so currently the penalty calculations under PQRS include your electronic health records meaningful use, so your EHRs and your MUs, and then the value-based payment modifier. Those would end in 2018. And then that's when CMS will move to this new MIPS, which is part of macro, which again will be based upon, it's kind of taking those our current reporting or programs, and then turning it into this MIPS, which again will be based upon quality, resource use, meaningful use, and clinical practice improvement activities. So basically the same thing that we're kind of reporting on now. So you're going to have to be able to show quality, so improved quality of care from the patient perspective, outcomes. You're going to have to show resource use, so lowering costs, better utilization of resources, meaningful use, which ties to your EHR initiatives, and then clinical practice improvement activities. So again, processes and things like that. So I think it's just kind of taking what we're doing now and ramping it up a little bit. And again, I can provide offline some really good articles I think that can do better justice, explaining this, because both of those questions are very loaded and it's hard to answer in just a couple of minutes. Maria?
Thanks, Kim.
Hello?
I paused. No, absolutely. Actually, while we were on this call, I was receiving quite a few, emails from some colleagues regarding this, because it is such a transition period, and it's really changing the way we do business. specifically from a reimbursement perspective, you know, as you look at bundled payments and so forth. So great presentation, Kim. I think we are at a close for today's presentation. I want to thank everyone for joining us today for the impact of the value-based purchasing in the healthcare industry. Sometime tomorrow afternoon, for all of you registered attendees, we want to thank you for joining us. Please fill out the survey that you will receive sometime tomorrow afternoon. You'll be able to obtain your CEUs after you fill out the survey, and please do so, as we always want to know how to better serve you. Thank you all, and have a pleasant day.